at the Center for Bioethics. We have a great events page with all those listed. We even have a couple that we're planning to do in person in April, if please gosh we get through this. So everybody, welcome to our second HERE talk, Health, Equity, Race, and Ethics. And we are just lucky as ever to have Dr. Sotto with us. Dr. Sotto is a faculty investigator at the Center for Bioethics. That is not her most impressive chair and position. She has a far-reaching impact at our campus as vice chair at the Department of Medicine at the School of Medicine here, vice chair for Faculty Affairs, Development, and Diversity. We've been very lucky to have Dr. Sotto as part of our center really soon after she arrived in Indiana with a background in research ethics and in research regulation, as well as her work on many issues in race, ethnicity, and equity, as well as other issues and here and elsewhere. And so today she'll be speaking to us about humility in our ethics, a case for cultural humility and cultural safety in our research. And so we're very glad to have you here, Dr. Sotto, and to be the next installment of our HERE series. We have another lecture already scheduled in this series for, I believe it's in March or February, with Dr. Bill Tierney, many of you may know of. And we'll have that on our events page, and we'll let you all know by email as that comes up closer to time. So thanks, Dr. Sotto. I'll just go ahead and hand this over to you. Thank you so much.
Actually, Peter, can you let me know what do you see in the screen just to make sure that I am not in the presenter mode versus?
Yes, it is good. It is basically full screen. Well, at the bottom of the screen, we're seeing all of your slides. We're not seeing any.
So I just need to swap. Let's see.
Oh, perfect. That's it.
Okay.
You swapped perfectly. This is perfect.
Okay. Go. Excellent. Well, thank you very much. Let me move this here. Okay, excellent. So as usual, I am very excited to join you today and talk about this topic. I apologize for being a little bit late. There were just some technical difficulties. I want to explicitly state how happy I am that this HERE series exists, and kudos to the IU Center for Bioethics and the great leadership and the whole team of true health equity champions. I would like today to especially, it's something that I do, but I would like to especially acknowledge that IUPUI stands on the grounds of historic homelands of the Miami people, but also displaced a vibrant Black community. And this is not an empty announcement, especially in this occasion, because the concept of cultural humility was actually introduced to us by scholars, by Black women. And the concept of cultural safety has also its origins in indigenous communities. So I do not have any other disclosures other than the fact that I have biases like everyone else, and those will come through as they come through in every talk I give. Today, I intend to go over the concepts of cultural humility and cultural safety, and I hope that we can have enough time to actually have a discussion about these. See here. So let's start with what is humility. Our trusty dictionary, Merriam-Webster, talks about humility as this quality or state of not thinking you're better than other people, the quality of state of being humble. It also says that it's the freedom from pride or arrogance. And that's where I would like to explore a little bit more right there. In case you didn't know, there is a book called The Handbook of Humility. And as far as I have read so far, the authors think that the handiest way to get the concept of humility as a virtue is to focus on what they call the vices of pride. And these vices are related to being smug, arrogant, they're related to vanity, envy, and some domination. And of course, they are directly opposed to the virtue of humility. What all the vices of pride have in common is that they're rooted with the concept of self-importance. Apparently also, Aristotle wasn't a big fan of humility. For him, modesty and humility were actually produced by a deficiency in sincerity, or so I'm told. I'm also told Socrates' wisdom was derived from recognizing the limits of his own knowledge, which is part of humility. But you didn't join today to join the Dr. Peter Schwartz lecture on philosophy, and it's not something that I am extremely knowledgeable about. But this self-importance comes to play a lot, especially in medicine, and especially when you're the one with the answers. So I've been asking my family and friends for a while to tell me about their clinical encounters, and anytime they feel that provider or somebody in the healthcare setting has actually demonstrated humility. This is a direct quote from one of my best friends, and you may call it many things when it comes to physician-patient relationship, but this is what this patient, an immigrant, saw as his provider's humility. He said, "My doctor found out that I had recently lost my brother to cancer. He took about an hour to speak to me and listen to me. He actually had tears and gave me a hug afterwards and provided his personal cell phone number." Now, this is a primary care provider. He also always asks many questions about him, about Ethiopia. You may ask how that provider carved an hour, but don't think too much about that. But think about how many times you haven't cared about productivity, but being there for your patient. You know, how many times you have afforded, even if it's just those 15 minutes, to truly connect at deeper levels with patients. Now, I have read a lot of personal statements in my lifetime, and none of them has started with, "I want to go into medicine for the money." I haven't read anyone that actually has said that, "I want to go into science and research for the glory." So in what I hope is a soon to be published paper, we hope that we make this point that cultural humility can be used to advance these health equity conversations, but also that it's a true opportunity to treat the patient and not the culture in a way that cultural competence leads us to believe. And we obviously should question that. What does this mean for cultural humility? That it starts with us. With each individual's journey of self-reflection. The golden rule, I think, tells us that treat others as you would like to be treated. But when you really think about cultural humility and the concept of cultural safety, as I will discuss today, we're really talking about treating others the way they want to be treated. As you know, or maybe this is news to you, but my work greatly centers on equity, on inclusive excellence, and cultural humility. And I try whenever I can to honor the work of Drs. Tervalon and Murray Garcia for getting us to critically examine what we meant with cultural competence and introducing cultural humility in 1998. They define cultural humility as this lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but the individual starts with an examination of their own beliefs and cultural identities. They really think about cultural humility as a process. And what is involved in that process are these principles, although thinking that they may lead to cultural competence, but again, that's not the goal. So thinking about cultural humility, again, as lifelong learners and reflective practitioners, that it is a process that checks the power imbalances that exist in the dynamics of patient-physician communication, but also, again, we're going to talk about the context of research ethics. And it is a process that requires humility to develop and maintain this mutually respectful and dynamic partnerships with communities, which is also really important in the research that we do. I like to bring in the cultural competence concept because it is important. I think that we have all been socialized, especially in medical education, to think about cultural competence as part of accreditation for many decades. But it's really this understanding of the importance of social and cultural influences on individuals' health beliefs and behaviors, and considering how these interact on multiple levels with the healthcare system, and for us to really think about interventions that take these issues into account. But as we know, that is not necessarily enough, because competence does have this notion of an endpoint, which is, you will be competent, but you can't be competent in every culture of the world. That's just not possible. These authors, Jaeger et al., talk about this difference. We can identify the differences in these approaches of cultural competence and cultural humility in the way that we view culture. For example, cultural competence may be more inclined to think about these group traits, right? Especially when we're talking about health disparities, and we actually put individuals in a bucket, either Black, African American, or Hispanic, Latinos, etc. When you think about cultural humility, again, you're thinking about the uniqueness of those individuals. The list goes on and on. I don't intend to go through all of them, but you can see as well that the definition of culture is quite broad, fluid. I think that it acknowledges that all of us are members of multiple cultural identities, but that we're not necessarily determined by this defined way, especially as they talk about us in terms of minorities or racial groups. Traditions is another example where competence makes us think that immigrants and minorities follow specific traditions, but cultural humility really tells us that everyone follows traditions, right? And if you think about your own family, what traditions they follow, they may greatly differ from even people that are part of your extended family. And lastly, again, that this, the endpoint is competence or expertise, whereas cultural humility, we're really talking about humility and flexibility. So, again, in the application to research, we're really thinking about cultural humility as this process of reflection and lifelong inquiry. It involves the self-awareness of your personal bias and sensitivity to cultural issues of others. So for it to be applied to research, it starts in the same way, where the researcher should be intentional about their own reflections of their values and biases and why you're doing this work as a researcher. The authors of this particular paper actually talk about the cultural humility being an essential component of training for clinical researchers, and that investigators can implement meaningful and ethical principles to better address and minimize health disparities. So at the very core, again, is this goal of reducing or eliminating health disparities and advancing health equity. And we do that through our own research. How many times do we sit down and think about the researcher's perspective, or I'm sorry, the participant's perspective that is not bound by that IRB application or the regulatory framework, right? So when we think about cultural humility in research, I would just like to highlight that, again, in this process of reflection, we are peeling, if you will, the layers that make us as an individual, that incorporates not only your personal, but also your professional and research values. I don't know how many of you, and I love giving out homework. So one of my homework after this session will be for you to actually think about not only your personal and professional values, but your research values. What is guiding your research actions as well? And then in the personal review, again, that you're really putting yourself in the shoes of your participants, right? That you're really taking into account the participants' perspective. So in terms of, again, this introduction of cultural humility in research, we're really talking about your ability as a researcher or research staff to provide high quality research that takes into account culture and diversity of a particular population when developing your research ideas, conducting the research, and exploring the applicability of the research findings. And many times when the only time that we think about diversity and health disparities is really when we're looking at the outcomes data, not necessarily really incorporating it from the very beginning when we are designing our research. Second is that this awareness of unique and defining characteristics of the population for which we are providing care and from which we want to enroll in clinical research. It's really important. In some ways that we can do that, at least that I can think of applying cultural humility in research, is it aligns with many concepts of community engagement and trust. So for example, building trust and understanding the groups, individuals, and populations that you're recruiting for initiating that research, developing the skills for communicating and learning about customs, values, and beliefs, having a working knowledge of your biases without stereotyping coming in the mix, and obviously your own commitment and motivation as a researcher. But that is not enough. I think cultural humility, again, maybe I'm idealistic in nature. I think that it applies in so many aspects, not just in the clinical encounter, but even in our one-to-one relationships. But it's not enough, especially when we're thinking about clinical research. So I want to introduce to you another concept, and that is cultural safety. I always talk about how the way we do research is very much positioned from dominant epistemologies, right? That when that most of the knowledge that we are endorsing in medicine is superior to other methods or other types of research, leading us to ultimately marginalize what could be considered other cultural strengths. And I always bring the example of my own identity. One of my many cultural groups is being a Latina woman, more specifically Puerto Rican, and how in my qualitative research, I would love to incorporate testimonials, for example, as a method. And it is not very much welcome by many journals because they don't understand what testimonial means for my particular identity, for other Latinos, right? Really telling us really their story. So from that aspect, it doesn't quite align, right, with what is the dominant epistemology. And the list goes on and on and on. And I think that's why cultural safety is important, because it was first proposed by Indigenous scholars trying to fight against that a little bit. And they define this as a focus for the delivery of quality care through changes in thinking about power relationships and patients' rights. So really, it's about acknowledging the barriers that we have in terms of effectiveness, clinical effectiveness, or research effectiveness arising from this power imbalance between provider and patient, or researcher and participant. It does reject the notion that as providers, you should focus on the cultural customs or traditions of your patients, but it shifts things really to think about cultural safety in a way that achieves better care by being aware of the differences, by decolonizing as I love to talk about decolonizing medical education, but really decolonizing the way that we do things, considering, again, those power relationships, implementing reflective practice, and allowing the patient or the participant to really determine whether they feel safe in that particular relationship. So as cultural humility is required, to examine, ourselves and the potential impact for that our own cultures have in those interactions. Here it goes a little bit further, and it's saying you have to question your own biases, you have to question your own attitudes, assumptions, stereotypes, prejudice, and the list goes on, that may contribute to an unpleasant or unsafe encounter, either with a patient or a research participant. So again, it just moves a little bit away from thinking about that particular individual as exotic or marginalized, or, this is a separate group, but really putting the onus on us. So there are some tenets related to cultural safety in research. One is that it acknowledges that the methodologies can be really better if we actually think about the fundamental right of those that are being researched. That if we're thinking of vulnerable populations, we're thinking about the truth in terms of experiencing inequalities in health, and really question if the research is beneficial to those that we say we're researching and it's crucial to address, right, these health disparities. And really admitting that vulnerable populations are often exposed to research that, again, is driven by those dominant ways from a sociocultural lens that can really exacerbate that vulnerability, negating, again, the reality of where we are, especially around marginalized populations. So lastly, in this specific slide, the authors here, Curtis, they talk about this framework of partnership, participation, protection, and power. And I love the 4 Ps because it truly, I think, could inform research design, especially when you're thinking about, okay, who are my partners? Who are the participants that we're trying to enroll in the study? How do we protect them? And how do I acknowledge that there is a power imbalance there that may not allow for that cultural safety in research? Here is another model, and I will not go into detail into this one, by Wilson and Neville, related to cultural safety. But I will say that basically what they're telling us is that people need to believe that the research that we're doing is connected to their lives, that they are involved in their research and that they have choices. And that the researchers has really have demonstrated this genuine commitment, that your desire for NIH funding does not actually exceed, right, your genuine commitment to actually doing this research. So that, again, that this objective needs to be clearly linked to achieving health equity, that there needs to be accountability for providing culturally safe care and research, and that perhaps really it needs to be defined by those individuals in those communities, right, those participants, and ultimately that we measure that progress through achieving health equity. So again, for cultural humility and cultural safety, we're really talking about achieving health equity and using these tools as a process to get us there. It's not that they're putting down cultural competence, but we can have a whole other conversation about cultural competence and stereotyping. So to summarize this a bit, I want to say, again, reminding us that cultural humility, when used by the researcher, is the process of reflection, including this unpeeling of the layers that makes us a person, and incorporating that professional, personal, and research values in your research actions. And when we think about cultural safety in research, we're really talking again about that reflection and how the practices may impact your research process. I'm not ending the talk yet, because I still want to talk a little bit more about this humility in ethics. And I have already shown you cultural humility again from an academic medicine standpoint, but I introduced to you again work from indigenous scholars. This one actually comes from social work, where they state that humility is really having this sense of one's own knowledge that is limited, that we're limited because we have our unconscious stereotypes and tend to use those stereotypes as a safety net to explain a behavior. And you can think about this over and over again, especially when you're thinking about clinical encounters. Just yesterday, in FCP, and I don't know who the participants are here, but I will provide an example. We were discussing actually poverty and structural and social determinants of health, and the case that was brought up as an example for discussion. Again, this is standardized for all foundation of clinical practice classes for first-year students. Talked about Native American, a Native American example. And although the case had all the key examples of how to target this question and reflection about poverty, it is always linked. I still have to find in my 15 years in academic medicine, a case where we're not talking about Native American population that is not related to alcoholism, mental health, or addiction. And that was exactly what the case provided yesterday. So again, even in medical education, we are creating and perpetuating, right, some notions of stereotype under the name of cultural competence. So again, thinking of your own training as a researcher, as a clinician, you can pretty sure pinpoint, right, those instances. And that has definitely contributed to health inequities. We are also limited in what we can know everything, right, about every culture. So we are better off thinking about how our identities in membership into different cultural groups may actually intersect. So that might be a better approach. So when you're bringing yourself into the mix, of course, I'm bringing myself to this conversation, hopefully authentically, but I can tell you that my favorite thing about cultural humility, and people have heard me say this over and over again, it's the curiosity and the freedom that comes with saying, I don't know. So I feel very comfortable practicing cultural humility because I am in that constant stage of thinking, reflecting on my interactions, on being curious about others, and the freedom of saying, I don't know. And I don't know how many times we get that, that opportunity to say, I don't know. So, in closing, what is humility in our research ethics? I put this definition here, and you can tweak it as many ways as you want, but I think about it as this lifelong process of self-reflection, curiosity, and willingness to learn from those who we serve and care for. It is truly thinking of participants, of our research participants as co-creators of knowledge, right? That they're not subjects. I know that we have moved from human subjects to participants, but still take it a little bit further and let's think about them as co-creators of that knowledge. So with that said, I will stop here for discussion. Yep. I made it. Even if I was late, I think I made it, but I will stop here for discussion, as I always enjoy these talks, mostly not for hearing me talk, but for the conversations that we have and how we learn together, and how much I learn from all of it.
Dr. Sotto, I'm going to let you field your own questions. If people would just put up their hands, or I guess it's quiet, you can just go get started. But Dr. Sotto, just go ahead and call on people as they want to engage you. Thanks.
What do we do if they don't have questions?
We'll cross that bridge. There'll be plenty of questions, I'm sure. With this group, we're gonna have to cut them off at 1 o'clock or maybe 1:30. So
I see some
anyway,
friendlies.
please go ahead, and if you can use the reactions thing to raise your hand. If you have to use chat, go ahead. I think we probably prefer verbal if we can.
It says Tracy Wilkinson raised a hand.
Hi.
Hi, Tracy.
Thanks so much for this talk. It was amazing. You mentioned med school statements, and it made me think about like how we as a community can like make sure that this is present, or that an applicant can learn some of these concepts through their training. And because I feel like I meet people that are so far in that it's hard to change. And so I just would love your thoughts as to how we as a community can do better at making sure the pipeline is full of people that understand and are excited to learn about these concepts.
Oh, that's a really good question, and I may have to switch it a little bit if you allow me. So recently, in the past few months, I published a paper with great colleagues talking about anti-racist medical education, and the reason why I'm switching a little bit, it's because in this paper, there was something that we actually make very clear from our observations on the medical students and graduate students that we're receiving in our academic health center. And it is their years and years and years apart from faculty in their understanding of issues of diversity, equity, and inclusion, and their use of concepts that our faculty that have been, in our systems for many years are not familiar with. And also this idea, my doctorate is in higher education, so I spent a lot of time in the higher education literature. I know what is happening in terms of student affairs, and this is actually an intentional movement in higher education to really talk about diversity, equity, and inclusion, social justice, and all those things. So at many points in my time at IU, more specifically, I've had students that have come to me and have said, Dr. Sotto, we would love to talk about intersectionality. Can you host an intersectionality conversation with our SIG? How many of our faculty actually have heard of the concept of intersectionality, and how many of them are using it in the wrong way that was not intended? So Tracy, I do think that the students that we're receiving in our pipeline are certainly more open to discussions of diversity that are related to diversity, equity, and inclusion, like cultural humility could be. I think they're open, they see it, they understand it, they can apply it very well when we actually talk about, again, structural social determinants of health. But my bias, and I said from the beginning that they will show up, my bias is truly in this faculty and professional development aspect, that I know the students are ready, they want the conversations, but I want our faculty to really feel comfortable, really in communicating, again, these concepts and these notions, and that includes cultural humility. So I don't know if that answers your question, but cultural humility is now embedded, I think, in the first year medical students curriculum. Actually, I think it was my first year here that I talked about. I was called to do a cultural competence session with first year students. And of course, I completely flipped it by the third slide and talked about cultural humility. So I think we're getting there. I do think that we need more of it in the research realm. I do think that there is a way to incorporate it with our graduate student pipeline and thinking about it, again, from the very beginning in research design. Is that fair, Tracy?
Yeah, that's great.
Okay.
Sorry, I couldn't find my mute button.
Okay.
But yeah, I totally echo what you say about generational differences. And so I think that's awesome that that's already incorporated, and it makes me feel really old because that was so not a part of my education.
I know, and that's the main, the main conversation that we're having, right? Especially with faculty. You have done a lot in terms of practice and under this cultural competence framework that has been part of accreditation in academic medicine forever. So I usually say that if you want, as a faculty member, to start incorporating cultural humility, you just have to ask one more question. So when you are with medical students and doing rounds, or you're with graduate students, I mean, what would it look like if you just ask one more question and said, okay, so here's what is happening with this particular patient. How would it be different if it was somebody else? Somebody else that was a member of another cultural group or had a different identity. That doesn't take a whole change in the curriculum. It's about us just asking one more question. I think the same can be said for research, especially as we talk about how our research is impacting health equity. I think we're going to be forced to think about that. Any others?
Nobody else talks, I'm good for it. But let's get somebody else, raise hands, or really at this point, you can really unmute yourself and talk if you'd like. I see Bill has taken the bait. Thank you, Bill.
I abhor silence. I really appreciate this talk, and I guess I have a specific question about research. How does community-based participatory research, how is that a potential means of partnering with the community to help identify topics, foci of research, and developing research programs that are culturally competent and enhance the humility of the investigators?
I think you know what I'm going to say, Bill. I think it's everything. I really think as community-based participatory research, or action research even, as something that should really be incorporated in biomedical research in ways that we don't often see. I am really proud to be sitting also within the Indiana CTSI, and I am always in awe about the massiveness of our community engagement piece all throughout the state. I do think that if we think about community-based participatory research, if we teach about it, even in biomedical research, that we can achieve better research design, right? Because in that sense, we're really doing research that is guided by the community, by what is impacting that particular community, informed by the community, right? And they can truly be, again, in my definition of what it would look like, they can truly be co-creators of that knowledge. So I in short, Bill, I think that there's a lot of tenets of community-based participatory research, of action research, that we can truly borrow in our research endeavors. Was that a satisfactory answer?
Yep.
Okay.
No, and I know you're engaged with CTSI. I just got off their strategy call and we talked about this. And so I think it actually, you can talk a lot about it, but you got to do it, and you've got to show that the participants is not just hand waving, that they actually are true co-investigators, which means you have to figure out ways of supporting their work in these things and engaging them as true partners. And that's a journey.
Good. I didn't see you. We were on the same call, Peter, Bill.
Right. And that is the topic of Dr. Tierney's next HERE talk in the next couple of months. We'll send everybody about how he, in the role down in this other position down at Dale Med School, engaged with the community to try to affect health outcomes. So it's a perfect progression to go from what you're talking about, Self, to Bill's experience in Texas as part of this series. I had to say that, although again, I will not step on the time for Rich and Kara. Go ahead.
Were you handing it off to me? All right. So first of all, thank you so much, Silk. It's always a pleasure to hear you speak and on topics that are so close and dear to you and to the community. I guess I have a comment more than anything else, and the comment has to do with the potential uses of data once they've been produced. And what I mean by that is you might be engaged in a community-oriented participatory research project, and I can cite one that I was involved in the early 1970s that was sponsored by the Macy Foundation. It was an enrichment program where after school kids got all kinds of enriched activities. And at the end of the day, it didn't show any difference. And the foundation decided that they were going to embargo the results in perpetuity because they felt if these results got to the public to say that millions of dollars were spent and there were no measurable differences, this was largely quantitative and not qualitative, that it would be harmful to similar programs that Macy and other foundations like the Ford Foundation at the time were sponsoring. So that's a case where the foundation has taken on the task of limiting how the data is going to be used. But in many communities, in communities of color where research is done, that research sometimes finds its way into the police, for example, in being used for crowd control. So I think it's important as researchers for us to think not only of our local circumstances, but also of the larger circles in which our research may wind up.
Used against. Yeah. Thank you, Rich, for that comment.
Sure. I saw Peter shaking his head. He either has essential.
I was just, were you
tremor or
endorsing
he was
suppressing
agreeing.
research results?
He was not endorsing suppressing research results.
Were you endorsing that? Because you were saying they suppressed it. You didn't say that. You said we need to take into account larger impact of our findings. I thought that was an implicit endorsement of suppressing the results. I assume you were not.
No, I was
Okay.
not. And
You were unable to.
none of the, yeah, go ahead.
No, but you were able to publish, or you were unable to publish given the agreement.
Correct. And I was just a research assistant at the time, so it didn't fundamentally impact my career. But for many people, including the principal investigator, it was a limitation of academic freedom, no question about it.
Yeah.
Sorry, I'll get out of the way.
Thank you.
So Silk, I think this pulls on Bill's question about community participatory research. But as you said, your case about a Native American individual in your class or whatever was, geared towards alcoholism or poverty or those types of things. Have we engaged communities in sort of community participatory education for the medical school? So have we engaged communities to have them talk about the scenarios and how they want to have themselves viewed within a case and what their primary issues are, so that we create cases that reflect the reality within a community? I guess that's one question. And then I think I've been in multiple conversations about how to create spaces where communities can help train our scientists so that they can, that they're part of the training of scientists within, so that they can effectively engage communities and prioritize things. So anybody who has ideas about how to do that, love to hear them.
So thank you, Kara. So to your first question, here's my humility showing. I don't know. And the reason why I say that is because I don't doubt that certain academic medical centers in relation to medical education and where they are located they might be indeed engaging the communities. For example, I can think of University of Minnesota Duluth having now the largest number of Native American medical students, right? So that was intentional in the way that the campus was established and what they were going to do. So I can't say because I don't know, but part of me says I don't doubt that there are other academic medical centers that are truly engaging communities in their medical education in a way that actually transfers to these cases, because the case-based medical education is huge, right? The same way that cases are used in business school, they far exceed, right, medical education. So I think that it's an opportunity for us to actually do a little bit of more of that, especially where Indianapolis and the School of Medicine is located, right? That there is a land acknowledgement that we have taken over, right? Land of indigenous people, and that we have actually displaced a Black vibrant community. So it should be, in another paper that I published, encourage academic medicine to think again about their social mission. So I think that is important. From your second point, as director of All In for Health, this is a conversation that we're having a lot, especially in the past 6 months, because I would love that. I would love for community members to actually teach researchers in the same way that All In has been committed to teaching individuals about health research, or about, telling them like, hey, here are all these health research opportunities. I would love to have that bidirectional communication. And I think that it's something that we are intentionally thinking about, but I can't tell you that it has been effectively executed. So I would enjoy my time with you talking about, again, how to and conceptualizing how that could work. Also, I do think that it's something that the CTSI really has done some work on, especially under CHEP and other programs, Research Jam and that kind of thing. So,
Silk, I want to direct your attention to two comments in, am I unmuted? Yeah, there are 2 comments in the chat. Let me take them in reverse order. David Craig asks, do you have your chat open by any chance?
yeah.
A question about why treatment is, apparently the report of mistreatment at the med school as well, and why that's still occurring. Why don't we take David's question first, and then we can address sort of this concern raised by one of our attendees.
Yeah, and I don't know if David wants to talk about it, but
sure. Because it was a little out of context, I'll just chime in.
Yeah.
Hello, thank you for that. I was just reflecting on the case that was shared about results not being released. And sort of this raises also questions about how we evaluate results, how we evaluate programs, what's accomplished by them. And something that's relatively new to me, and so I'm partly wondering if you have any experiences to share about it, perhaps, is this concept of participatory evaluation, where you actually create the evaluation goals, process, and really interpret the results with the participants. And this probably bothers us because participants shouldn't be able to cook the books of the results. But the idea, of course, is that why should the researchers get to set the agenda and what matters for positive outcomes, right? So I was just wondering if you had anything to share on that, because I'm trying to learn about it myself.
Oh yeah, the only time that, and I'll be honest, the only time that I have been involved in that, it was through my doctorate program, and partly because University of Denver did have a very strong action research arm. So in that sense, yes, community members were actually part of the creation of the evaluation. I don't know if they were necessarily, involved past that in terms of outcomes, but it brings up your point about participatory evaluation. And that is something that should be implemented, right, in any program evaluation, especially when it's aimed towards a particular community. So you have my full endorsement. However, I can't give you key examples right now because we haven't done it right now. I did do a faculty development program in which I had the pilot members, pilot of the program, and those members help with the evaluation. But I don't think that it was in any way systematic enough or evidence-based that I can, tell you to follow that path, if you will. But keep up the good work and keep me informed about how you're doing that. For the mistreatment question, why is mistreatment still happening? I don't know.
Yeah, can I jump in here? This link that's been shared in the chat, I appreciate, Mauro, if you don't mind using your first name. I really appreciate your sharing this. I wasn't familiar with this report. This is fascinating, interesting thing for everybody to look at. I will say this is a shocking level of transparency and a very encouraging one, right? That the med school would report out in an anonymous way the number of alleged cases of mistreatment at the university, and then the follow-up again in an aggregate fashion. It is concerning, certainly, that if you look at the response, I'm down here on some level. Which page am I on? I'm not sure what page. It seems to be a slideshow. But the results of incident reports, that basically 3 were level 4, 2 were level 3, 6 were at the level 2. So that's like you're saying, 11 in this year. Basically were ones where the review was deemed to actually indicate a problem and actually feedback to a faculty member, or even potentially teaching privileges or faculty appointment. So I don't know, we can close with this. We're actually at time, but Dr. Sotto, do you have a thought of what you think about the state of mistreatment in education, if that's an issue of humility or it's a different issue? I mean, in some ways, I'll leave that. I'll let you answer that question.
The reason why I say I don't know, and tomorrow it's I don't understand why. But of course, in my role for 5 years, co-chair of that diversity council, I have seen the mistreatment reports every year in terms of, again, this report. And, I saw the process being implemented and how it was conceptualized. I do think that it is complex in the way that can point many directions from the way that our faculty were taught themselves, right? Pimping was a thing. The way that perhaps they're, following their own training, mistreatment. And then there's other ones that are really bad. We have wonderful faculty, but we also have, questionable actions by our faculty. So I do think that it's a complex issue, but I do think that the school has taken it very seriously. And I hope that one day it will be, eliminated as an issue.
On that note, Dr. Sotto, again, thanks again so much for the talk. Please join us again for Dr. Tierney's presentation in about a month. We can send that out to the list after this. Again, thanks for your participation and questions. And again, Dr. Sotto, just what a fun and educational opportunity.
And again, I'm always available via email if anybody wants to continue that conversation or has, any thoughts, or if I said something that completely was wrong and against everything you believe, please let me know. I love to hear that too. Bye, everyone.